Is the screen visible?
Yes, sir.
Yeah, okay. Start.
Good morning, respected faculty members and my dear friends. Today I am going to present a case on lump in the epigastric region. A 55-year-old gentleman from Kolkata, West Bengal of Hindu religion, businessman by profession, presented with lump in the epigastric region of abdomen since 6 months. Dyspepsia since 6 months, occasional pain in abdomen followed by 1 episode of hematemesis last 2 months. History of present illness: the patient was apparently all right 6 months back when he noticed a feeling of small lump in the epigastric region on his abdomen, especially after the large meal. Since then, he gave a history of gradual increase in size of this lump to the current size of approximately 7 cross 7 centimeter. Patient complained of dragging sensation due to its lately. He also complained of sensation of fullness after meal and early satiety, more since the last 6 months, for which he has been taken over the counter antacid. No history of vomiting except 1 episode of hematemesis. He complained of occasional pain in the abdomen since the last 2 months. The pain is gradual in onset, burning in character. The pain was in the epigastrium without any radiation. There was no some aggravation of the pain after meal. He further gave history of episode of hematemesis 2 months back, for which he required hospitalization and he was given to a unit of blood transfusion. There is no history of lost height and weight loss. There is no history of yellowish discoloration of urine, eyes and urine. There is no history of abdominal distension. There is no history of breathlessness, cough and hepatitis. There is no history of hematuria, increased frequency or urgency of the burning maturation. There is no history of headache, convulsion, weakness of any limb or cranial nerve palsy. There is no history of backache or pain in any limbs. Past history: there is no history of any significant medical illness or surgical intervention. No history of any comorbidities like diabetic, hypertension, thyroid dysfunction or COPD. No history of any allergy. Personal history: patient is married, nuclear family comprising of a spouse, 2 sons and 1 daughter, all alive and well. Diet: Bengali mixed diet, bowel altered as described, bladder unaltered, habit. Family history: parents are not alive, died due to old age. He has 2 brothers and 2 sisters, all alive and well. No significant history suggestive of any malignancy in the family. Summary of the history: a 55-year-old gentleman from the Kolkata, West Bengal, presented with complaint of progressively growing lump of approximately 7 centimeters in the epigastric region of abdomen. Along with this, he complained of dyspepsia after meal since the same duration. Since the last 2 months, he has been having a recurrent episode of gradual onset burning pain in the epigastrium. Following this 1 episode of hematemesis. Beside this, the patient does not have any symptoms suggestive of metastasis. He has no history of any medical illness, surgical intervention or comorbidities. There is no significant history of any malignancy in the family.
Okay, wait. Yes, you can have some discussion on the presentation of the history.
So I forgot your good Nitin is your good name, isn't it, Nitin?
Nitesh.
Nitesh. Now at this point of time, if you look at the history that you presented, what do you think are your possibilities?
My possibility.
Forget about the clinical examination. At the point where you have completed the history, what are your possibilities?
Sir, possibility of CA stomach.
Okay.
Then, sir.
Let us say what are your anatomical possibilities. Let us not go into the pathological possibilities.
Yes, sir, anatomically the lump is in the epigastric region. So sir, anatomically, sir, the pathology could be from liver, stomach, pancreas.
On the background of his being early satiety, fullness, hematemesis, what do you think is the primary organ of involvement?
Sir, primary organ of involvement is, sir, stomach.
Yes. So think of something in the stomach.
Okay. So stomach, and as you told, it can be liver, from the colon or from the body of the pancreas, isn't it?
Yeah.
Yes.
Or a retroperitoneal. So always in the epigastric lump, these are the 4 areas: A, stomach; B, colon; C, liver left lobe; D, body of the pancreas; not head of the pancreas, body of the pancreas, and retroperitoneum. Okay.
Yes, sir.
Now, if you feel it is stomach, what histories you have taken to differentiate the different pathologies of stomach?
Sir, history, sir, if from different, like if from liver, sir, history of
No, from stomach, what are the possibilities you can think of, and what histories? Because you have missed one or two histories. That's why I'm asking you. If
Sir,
you think it's stomach, and what are the possibilities realistically?
sir, history of hematomasis, history of melena, sir, then loss of appetite, sir, then sir, sir, vomiting in case of gastric outlet obstruction.
So realistically, now let me ask you a straight question. What are the possibilities of lumps arising from the stomach?
Sir,
55-year gentleman. Keep in mind that also.
Yeah.
Sir, sir, CS stomach, sir.
Yes.
Sir, gastric lymphoma.
Gastric lymphoma. Now, if you think it can be a gastric lymphoma, either a primary lymphoma or a secondary lymphoma involving the stomach, what other histories you should have taken? You have missed certain histories.
Sir, sir, we'll ask for the evening rise of fever. In case
So
of
night sweats,
night
fever.
sweats. Yes, sir.
Didn't you have missed those histories, isn't it?
Yes, sir.
Yes.
And any swelling in the other parts of the body.
Yes, sir. Any swelling in the other parts.
of the swelling. That's what I was trying to ask you. If you consider gastric lymphoma as one of your differentials, you must ask about fever, night sweats, and of course more than 10% weight loss.
Yes, sir.
And you, as you rightly said, rest of the thing can be a cyst or a carcinoma stomach, which I am happy with. Okay. Now, if you consider some swelling, not looking at the hematomesis in that area, you told the possibilities of liver, and you have told also that there is no history of jaundice. You told that it can be a body of the pancreas lump. Now, if it is a lesion arising from the body of the pancreas, what possibilities you can think of, and what histories you should take?
Sir, if it is from body of the pancreas,
What are the usual lesions? It can be, if it is a tumor, what are the different types of tumor involve the body? Some tumor may be large in size also.
yes.
Like what? Benign tumors include what? In the stomach, in the pancreas? Cyst adenoma.
Cyst adenoma.
Cyst adenoma.
Adenoma. Okay. So what features you will take to exclude possible benign or malignant swelling arising from the pancreas? Look at the benign swellings. Beyond tumors, what are the possibilities?
Sir, from the pancreas.
Yeah. Look at the common things, which later on can present with hematomesis as well. What are the common lumps or swellings that can arise from the body of the pancreas? Forget about your case. Just tell us.
Benign, sir.
Yes.
Yes.
Yes. Cyst adenoma is one. Then apart from this, it can be carcinoma from the body.
Yes.
So it can be a carcinoma from the body, and in which case the patient will likely to present with a pain radiating to the back.
Back, yes, sir. Pain radiating to back and weight loss.
In this case, it's a localized pain, burning in sensation, and there is no radiation from the back. Accepted. Can it be, say, a pseudocyst arising from the pancreas? If you expect a pseudocyst arising from the pancreas, then what would be the preceding history?
There must be a history of acute pancreatitis in the past, like 1 month or 20 days back.
Very good. And if it's a chronic pancreatitis, what will be the presentation like?
Pseudocyst may occur in the chronic pancreatitis. In that case, what features this patient would have?
Sir,
Long-standing history of
long-standing history of, sir,
chronic pain.
Chronic pain, sir, continuous dull aching pain.
Chronic pain, then steatoria.
Steatoria, sir. Yes.
And also endocrine dysfunctions
Yes.
might be present in these patients. Now, I ask you another leading question here. Can a patient of chronic pancreatitis leading to pseudocyst present with hematomesis? If you can answer this question in physical mode, I will give you one toffee.
What can happen? If there is a chronic pancreatitis, pseudocyst, what secondary things can happen which can cause a hematemesis?
Sir, pseudocyst, sir, that lead to, sir, pressure symptoms in the stomach.
Not only stomach.
There
There are some veins around, some arteries around which can have some changes. What can happen?
Sir,
so what is there on the superior aspect of the pancreas, superior border of the pancreas? Which
Splenic artery hai, splenic vein
artery.
hai.
Yes, sir.
क्या हो सकता है?
Sir, yes.
So if there is
Thrombosis,
a,
sir. Yes.
yeah.
Thrombosis, sir.
So there are two possibilities. Let me answer the question. One is there can be a thrombosis of the splenic vein which lead to a portal hypertension, and portal hypertension can lead to bleed. This is one condition. Number two, it can lead to pseudoaneurysm arising from the splenic artery. As a result of which there can be a condition called hemosuccus pancreaticus. Okay?
Yes.
So once you tell the possibility of a pancreatic lesion, as Sir told, benign lesions like cyst adenomas or cyst adenocarcinomas. Number two is pseudocyst and its consequences. So they can also be a differential. Okay. Now you told about accepted colon. You told there is no change in bowel habit. Now, if I suspect that this is a mass which is arising from the retroperitoneum, I mean, say a metastatic mass or a lymph nodal mass in the retroperitoneum, and this being a male patient, what other histories we would like to take?
Any swelling in the scrotum.
Sir, swelling, any swelling in the scrotum.
Very good, in the scrotum. So that histories you must take, okay? Because a testicular tumor might present with a metastasis in the epigastrium. Clear?
Yes, sir.
So
what is the structure there? The metastasis occurs in the epigastrium. What get enlarged in the retroperitoneum in testicular tumor?
Lymph
nodes.
Lymph
Yes.
nodes.
Lymph nodes.
These lymph nodes are in the level of L1.
Okay.
Yes.
So if we once again revise for the sake of everybody to remember, we can have stomach, and of stomach we can have a carcinoma stomach, of stomach we can have a cyst, of stomach we can have a lymphoma. We can have a lesion arising from the left lobe of lesion. We can have a lesion arising from the colon. We can have a lesion arising from the retroperitoneum. We can have a lesion arising from the body of the pancreas. Now, of the retroperitoneum, the possibilities is a metastatic lymph node. It can be a primary retroperitoneal tumor which has invaded the stomach, and it can be tuberculosis as well, presenting with the retroperitoneal matted lymph nodes. Okay, so that would be the whole block. We can proceed if you want to.
And if it is a retroperitoneal tumor, mostly it is not producing any systemic symptoms like GI symptoms or whatever. In retroperitoneum, this just lump grows and patient may not have any symptom suggestive of outer obstruction, hematemesis. In that case, suspicion become more that it might be retroperitoneal tumor.
Yes.
Okay. Awesome. Examination.
Sir, after general
Brief. Yeah.
Sir,
Sir,
Sir, after proper informed consent, patient was examined in the supine position in the well-lit room. Patient is alert, oriented to time, place, person. Build is average, nutrition is average. There is no indication of any micronutrient deficiency. BMI is 20.6. Karnoff scale score is 90. No pallor icterus, clubbing lymphadenopathy. Patient is afebrile. Vitals are within the essential limit. Abdominal examination. On inspection, the abdomen is not distended, but there is a fullness in the epigastric region. Umbilicus is central in position and inverted. No scar and pigmentation or dilated vein noted. No movement with respiration is noted. Normal movement with respiration is not noted. No obvious swelling noted over the abdomen and hernial sites, even on cuffing. External genitalia appears normal. On palpation, temperature not raised, no muscle guarding. Firm swelling is palpable in the epigastric region. Lump is intra-abdominal. This is confirmed by leg raising and head raising test. Globular in shape with smooth surface, not indenting. Approximately 7 × 7 centimeter in size. Swelling is not freely mobile but has some liver, spleen, kidney not palpable. On percussion, general tympanic note, abdomen, and dull note over the lump. No signs of ascites. Upper part of the liver dullness noted at 5th intercostal space in mid-clavicular line. Liver span is 12 centimeter. On auscultation, normal peristaltic sound heard. On upper rectal examination, there is no abnormality noted upper rectally. Systemic examination are essentially normal. Summary of the case: 55-year-old gentleman from Calcutta, West Bengal, presented with a complaint of progressive growing lump of approximately 7 × 7 centimeter in the epigastric region of the abdomen. Patient has complained of early satiety after the meal since the same duration. He has also recurrent episode. He has also a gradual onset burning pain in the epigastrium and 1 episode of hematemesis. Besides this, the patient does not have any symptoms suggestive of metastasis. There is no history of any medical illness, surgical intervention, and comorbidity. There is no significant history of any malignancy in the family. General physical examination is essentially normal. Vitals are essentially normal. Abdomen examination revealed a smooth, globular, slightly mobile, firm intra-abdominal lump in the epigastric region, measuring approximately 7 × 7 centimeter. Per rectal examination was normal. Systemic examination was also normal. Provisional diagnosis: a 55-year-old gentleman with a lump in the epigastric region with a foreside history and examination is most probably suffering from gastrointestinal stromal tumor arising from the stomach.
Can you go back to your character of the lump once again? Okay. Now, I understand this is a very brief presentation. Now, if I want you to detail the lump in this case, how would you detail it? Now, start your palpation right from the beginning, quadrant wise, okay?
Yes, sir. Sir, lump, lump is in the epigastric region, palpable in the epigastric region, globular in shape, and surface is smooth, size of 7 × 7 centimeter.
What is the consistency of the lump?
Sir, it is firm in consistency.
Okay.
Yes. So lump is intra-abdominal.
Okay.
And so and it is not freely mobile, but has some movement with respiration.
So lump moves with respiration, and as such, is the lump mobile?
Sir?
Intrinsic mobility, hai? Yes.
Yes, sir.
In which directions is the lump moving? Above, downwards, or side to side?
So side to side.
There is side to side mobility, and there is also movement with respiration, isn't it? Now, is this lump pulsatile? How will you examine for pulsatility of this lump?
Lump is not pulsatile. Sir, for examination, sir, we have to see tangentially from the side of the patient.
Okay. And on palpation?
On palpation, we can feel the pulsation over the lump.
How will you place your fingers? I mean, if I mean, can you show your fingers up to demonstrate in which axis your fingers will be placed? Transverse or vertical?
Sir, for pulsation, we'll place the vertical, sir.
Okay. And which location you are going to place the fingers? Now, what realistically is the pulsatile structure you are looking at here?
Sir, pulsatile structure, sir,
Posteriorly.
posterior, sir, aorta, sir, we are looking for. Sir, if there is aortic aneurysm,
Yes.
so the pulsation will be.
Aortic aneurysm will cause intrinsic pulsatile.
Yes.
And if the lump is sitting on the aorta,
Then
what is
what
the
will be the nature of pulse?
Sir, transmitted pulsations.
Okay. So what test will you do to exclude a possible hernia in the epigastrium?
So
You told it's intra-abdominal. No confusions on that. What test will you do?
sir,
Clinical.
Sir, clinically, sir, intra-abdominal, sir, by leg raising or head raising test will do, sir.
no, but is a hernia. What can happen? What character
sir,
this swelling will have?
Sir, sir, if it is hernia, then sir, the lump will further increase or further increase in size or become
What will happen with cuffing?
Sir, cuffing the lump will, sir, increase in size, sir.
So you just add one line, the swelling is not reducible, there is no expansile impulse on cuffing. What we intend to tell is that now this is a situation where you have initially examined the patient, then you have got time to prepare it. But when you are going for the exam, do not jump steps. Every possible steps you go on mentioning. The lump is non-pulsatile, there is no expansile impulse on cuffing, the lump is non-reducible. That makes sense that you are excluding every possible thing. Okay?
Yes, yes,
otherwise, related to this patient, what you have told is perfectly normal. Okay?
And another thing is, Dr. Sagar, he is saying lump in the epigastric region. If you say lump is 7 by 7,
exactly.
you should always keep in mind that this lump is not going to be epigastrium. Because you have to keep in mind where the epigastrium ends, where the umbilical starts. So you have to say that way, because in the exam, the patient is in front of you.
Yes.
You cannot just go saying that lump is going to be epigastrium. This lump is 7 centimeter might go to the adjacent umbilical region also.
Yes.
Sir, I'm just trying to tell him that recently I was examining in one of the exams. The candidate exactly told like this. The examiner got up and told that you show me, and actually the lump was going towards the lumbar region.
Yeah.
Then the examiner told him what are the different zones in the abdomen. Then he was unable to tell what is the transtrabecular line, and the conclusion is you don't know anything.
Yes,
so
yes.
Don't give the examiner scopes like this. They can drag you down to any place. So draw a diagram and exactly tell what is the location of the lump, so that the examiner does not have any scope to ask questions to you. Okay, but these are very simple things. Now look at this, my dear. You have not mentioned the position of the umbilicus. I understand it's not relevant to this, but make it a habit that the umbilicus is centrally placed. Okay, inverted or everted, whatever you feel. The flanks are empty. I'm sure you have placed that in the
inspection.
Okay,
Umbilicus, yes.
Yeah, that's fine. I mean, these are small points, but do not jump steps. Okay.
And sometimes with this lump, the umbilicus may be pushed.
Exactly.
You should always be vigilant that a lump in the upper abdomen can push the umbilicus a little downward.
Okay. And again, external genitalia appears normal. And as I said, you have to mention that I have examined the scrotum and did not find any abnormal testicular swelling. Okay. And the other thing in the general survey, now always remember the rule. If you have an epigastric lump, do not forget to palpate the testis and the neck for supraclavicular gland. If you have a supraclavicular gland, do not forget to palpate the abdomen and the testis. If you have a testicular lump, so they come in three pillars. Okay, rest is fine. Okay, so you told it's a diagnosis is a gastric lump, possibly a gist, isn't it? So what?
But difficult in the exam. Suddenly you cannot jump to a diagnosis of gist. You should always keep in mind that what the patient presenting is. Now you justify.
You justify. Why do you think it's a gastric lump, possibly a gist?
Sir, There is a history of lump of 7 cross 7 centimeter. Age, sir, history, sir, age.
You see, you have to defend yourself by some points. A 55-year gentleman presented with such a lump,
Yes, sir.
and you are still trying to say that this is a innocuous lump, not causing much of outer obstruction or in distant spread. If it is a carcinoma stomach, you would have some more features. So you have to defend like that only, because it is difficult to give a clinical diagnosis of GIST straight away.
Yes,
But you have to take some points from this patient presentation and your finding.
Sir, 55-year gentleman, sir, presented with epigastric lump. Sir, there is one episode of hematemesis. And
Why patient with GIST present with hematemesis?
Sir, there is ulceration. Ulceration over the mucosa of the stomach.
Yes.
Okay. So as an examiner, if I challenge you, now I think it's a case of carcinoma stomach. How would you stand that debate?
Sir, in carcinoma of the stomach, sir, patient will have a history of.
You said in the history, patient has no loss of appetite,
yes, sir,
no significant weight loss.
Yes.
What do you expect in a patient of carcinoma stomach with such a lump?
Sir, patient present with loss of appetite, weight loss, significant weight loss, and sir, patient maybe a patient is will be anemic. Sir, patient may present with a symptom like symptom with a gastric outlet.
Yes, such a large lump in the stomach, which is a malignancy. In that case, outer obstruction is more likely. You see, it can happen, may not happen also.
Yes.
But patient presenting with such a lump and diagnosed unlike carcinoma, is likely that patient might have outer obstruction.
Yes.
The other point which you can take to defend that it is unlikely to be carcinoma stomach.
Yes.
Okay. Now I give you a tip. During the exam, there are two types of examiners. One group of examiners is going to ask you the possible differentials, and you tell 1, 2, 3, 4, 20, up to 25. And the examiner sits and hears all the 25 differentials that you give. The other group of examiners is going to challenge you, like the way I mock challenged you. I just negated your diagnosis and told I think it's a carcinoma stomach. So your answer in these circumstances, if I were a candidate, I would have answered, yes, sir, gastric carcinoma is a possibility. However, in case of a gastric carcinoma, I expect a long history of anorexia, asthenia, and weight loss, which is absent in this case. In case of gastric carcinoma with a 7 cross 7 centimeter lump, I definitely expect the patient to have a gastric outlet obstruction, which is absent in this case. However, the fact that the patient is presenting with a lump and melena indicates the fact that it is arising from the stomach. So it is likely to be a lesion which is arising from the stomach, but not compromising the lumen. Then on examination, I found this. Therefore, I thought it's a stomach-related mass, and the commonest possibility I could think of is a GIST.
So try to defend the diagnosis with the valid points. You should not deny that it's not carcinoma stomach. It will be lymphoma stomach, but clinically it is difficult to give if you give a lymphoma stomach diagnosis clinically, examiner you know the diagnosis. It's not required.
Yes.
Okay. So what are your differentials apart from stomach? And I suppose I ask you, this is a colonic carcinoma. How do you defend?
Why not colonic carcinoma? It's an epigastrium.
Yes.
He says slightly mobile. 55-year gentleman.
Sir, colonic carcinoma, sir, patient may present with features of obstruction and sir, abdominal distension.
Increasing constipation.
Increasing constipation.
Passage of mucus or blood in stool.
Yes.
Now, suppose it's a colonic carcinoma. Now, can you differentiate the pattern of mobility in a transverse colonic carcinoma versus a lump that you told, which is in this case? What will be the pattern of mobility of transverse colonic lump?
Sir, transverse colonic lump.
Will it move from side to side or will it move from above downwards?
Sir, above downwards.
And how is this lump moving?
Sir, side to side.
Side to side. So a gastric related mass will move from side to side, whereas a colonic related mass will move from above downwards. Clear?
Yes, sir.
You expect a transverse colonic lump to move up and down with respiration.
Sir, no, sir.
So a hepatic flexion lump might move, but a strictly transverse colonic lump is unlikely to move. In this case, you find that the lump you told is moving slightly with respiration.
Yes,
So it has to come in close proximity to the diaphragm. So these are the points which are directing that it's not a colonic lump. The symptoms as well as the signs are not in favor of a colonic lump. Okay.
Yes.
So realistically, how will you evaluate this gentleman?
Sir, first, to confirm the diagnosis, sir, we'll start with sir USG whole abdomen, which is an
Yes.
extension of.
You just say that as an extension of
Extension of
clinical
clinical
examination, I'll do ultrasound is a very basic investigation that a resident should do in the ward itself.
Yes, sir.
So start with ultrasound. Don't jump to the other diagnosis.
Yes, sir.
Yes. How ultrasound will help?
Sir, ultrasound, sir, will sir tell about any metastasis?
Before metastasis. This is a lump.
Sir.
So I already give the nature of the lump.
Yes, sir. Nature of the lump.
It's solid or cystic.
Yes, sir.
Then
Size.
Then we have some gross discussion. Retroperitoneum, pancreas, liver.
Sir,
So gut-related mass are better picked up by ultrasound or not picked up by ultrasound?
Sir,
Gut-related mass.
gut-related mass.
Poorly picked up.
Poorly picked up.
So you can see the pancreas.
Yes, sir.
You can delineate the liver in ultrasonography. You can see the lymph node mass in the retroperitoneum. So it will help to some extent. May not give a pinpoint diagnosis.
Yes.
Now, Nitish, when you are asked this question, you told at ultrasound. Now, what happens is that most of you as candidates during the exam, you tell ultrasound and stand there. I mean, what the examiner wants you is to write a short note on ultrasound in an epigastric lump. Okay. So as sir has rightly said, you must tell in totality. Don't stop at ultrasound. Sir, as an extension of a clinical examination, I am going to do an ultrasound of the abdomen. The ultrasound will be able to tell you the character of the lump. It can tell you the location of the lump. It can also tell you whether it is originating from the pancreas or the colon or the stomach. However, if the abdomen is grossly distended, it is very difficult to assess the organ of origin. The ultrasound can also tell me about presence of ascites or any other distant metastasis. So once you tell the whole thing, the examiner has no further question to ask. But if you stand at ultrasound, the examiner is going to ask you multiple questions. Clear?
Yes.
So you have done an ultrasound. What next?
Sir, sir, we'll go for CCT whole abdomen.
No. Your diagnosis is what?
Sir, this.
Yes.
Sir, we'll go for upper GI endoscopy.
Gist with the hematemesis, with the facility of CS stomach. So try to think. You said I will confirm my diagnosis. Do you think CT will give a confirmation diagnosis? It cannot. So next will be upper GI endoscopy. What? Your diagnosis is gist. What is the typical appearance of a gist when you do upper GI endoscopy?
Sir, in upper GI endoscopy, sir, we'll see the indentation in the mucosal wall, as it is a submucosal tumor. And sir,
so it's a submucosal tumor.
Yes.
So most of the time we find that mucosa is normal or stressed.
Yes, mucosa is normal.
Except the patient having a recent onset of hemorrhage.
Yes, sir.
What you can find in the mucosa?
So there might be, sir, ulcer.
Yes. Otherwise, you can comment that on endoscopy, the mucosa may appear normal with slight stretching.
Yes, sir.
And there is appearance of indentation. They comment that. What they comment in the endoscopy? There is what? Excessive compression.
Yes.
Indentation in the stomach.
Yes.
Okay.
Now suppose this is a gastric carcinoma. What will be the appearance of such an ulcer in gastric carcinoma in endoscopy?
Sir, gastric carcinoma, sir, will see the
If you say find ulcer, what is the character of a typical malignant ulcer on endoscope?
Sir, malignant malignant ulcer, sir, we'll see punch,
Margin, age,
yes, sir.
floor, adjacent mucosa. What are the changes?
Margin, sir, irregular, sir.
Yes.
Uh,
Age.
Age will be, sir,
What? Typical malignant ulcer? Raised and
everted.
Everted.
What about the surrounding mucosa?
So surrounding mucosa, sir, we'll see.
You will find the mucosal fold converging towards the ulcer, or you find there is some change in the mucosal rugosity.
Sir, changes in the
what change?
Sir,
there is a classic difference between a benign and malignant ulcer. What happens?
Is the difference in rugosity?
Sir, loss of rugosity.
Flattening.
Yes,
Okay.
Because of infiltration, there will be flattening of the mucosal folds around us. So that is a typical character of a malignant ulcer in the stomach. That is what is being asked.
Now, suppose if you find a malignant ulcer, how will you? And also the additional point is loss of distensibility, because when you inflate, the stomach is not distensible as it is in normal things. The next is, how will you take a biopsy? Suppose you get a rolled out everted margin with surrounding area loss of effacement of rugosity, etc. How will you take? How many biopsies will you take, and from where will you take the biopsies?
Sir, we'll take from the edge and the norm. We'll take edge and the normal tissue.
And do you divide the ulcer? Do you divide the ulcer into quadrants?
Yes. Yes.
Yes. So,
sir, will take, sir, I mean, minimum 6 biopsies.
Minimum, you should take at least 2 biopsies from each of the quadrants. So it will be 8 to 10 bits of biopsy.
Yes.
Okay, that is how you divide the ulcer area.
Okay. So you have done an endoscopy. What will be your next investigation?
Endoscopy suspicious of GIST.
This.
It is not a mucosa invading tumor. There is 1 point of hemorrhagic spot, but suspicion of GIST. What should be the next investigation?
So next investigation will be, sir, if endoscopic ultrasound facility is available, sir, we'll go for endoscopic ultrasound, sir.
Okay.
But you see, most of the time we don't see endoscopic ultrasound. In your practice, most of the time people are not coming to ultrasound. What is surgeon's usual practice to have evaluation of this tumor?
CCT whole.
CCT whole abdomen. Okay. What are the things you are going to see in a CCT whole abdomen?
Sir, we'll see the location of the tumor, size of the tumor.
What is the character of this GIST in a typical CT scan?
Sir, in this,
you are doing a contrast CT?
Yes. Sir, it is hypervascular heterogeneous tumor, sir.
What about the outline?
Sir, irregular.
No. GIST is not usually having irregular outline.
Yes, smooth, sir.
Usually having a smooth margin.
Lobulated appearance.
Lobulated, smooth margin, sir.
Okay. You can tell about the extent, the relationship with the sound. Again, it's a short note.
Yes, sir. The CT scan will tell about the locoregional spread and involvement of, sir, if any liver metastasis, if there is any liver metastasis, or to the pelvic metastasis,
and regional lymph nodes.
And regional lymph
GIST can spread by lymph nodes. Yes. So you should give the description of what changes in the CT will show you is likely to be GIST.
Now, another important thing that you are, if you are doing a GIST, you always tell whether there is extensive intratumoral necrosis or not. Okay. The reason I ask you is presence of extensive intratumoral necrosis is a sign of poor prognosis.
Yes,
okay.
Sir.
Now, will you take a biopsy? Yes, no.
No, sir.
No. Very good. When will you take a biopsy in a gist?
If sir, sir, if sir, if there is a high risk feature suggestive of
No. If I intact mucosa, biopsy you may avoid.
yes, sir.
But when you can take a biopsy and get a yield also.
Sir, if it if the tumor size is larger, more than 2 centimeter, sir.
If there is an ulcer, you can take a biopsy from the ulcer base, where the gist will be just deep to the ulcer.
Yes, sir.
Okay.
And then you have to take a biopsy and prove if you are considering a neoadjuvant treatment. You
Exactly.
cannot start neoadjuvant without taking a biopsy.
Yes.
So if it's an inoperable lesion
So it is
or a metastatic lesion, say multiple metastases in the liver, always take an ultrasound or a CT guided core biopsy.
Yes,
Okay.
yes.
Because it is best, because core biopsy will be able to tell you which is a c-KIT positive or a c-KIT negative gist, and therefore you can start using neoadjuvant systemic therapy. Okay, at my point. So if the indications are if there is an ulcer, yes, as sir told, you have to take a biopsy. Number two, if you find there are evidence of metastasis or inoperability, yes, you have to take a biopsy, and the preferred biopsy mode is a core biopsy. And okay, so you have got a diagnosis of a gist which is operable. Now, what is your plan of treatment?
sir, if in our case,
Yes, this patient gist, and you thought this is a operable situation.
sir, if it is sir operable, sir, we'll go for
Don't forget to prepare the patient.
yes, sir, we'll prepare the patient. We'll do the routine blood investigation, and sir, sir, the plan, sir, and we'll go for wedge excision or wide local excision with margin of 1 centimeter.
Are you going to go for a lymphadenectomy like in D2
No, sir.
gastrectomy?
No, sir. Sir, lymph node metastasis is very uncommon in this.
So you are not going to just go for a wedge resection, okay, isn't it? Now you have done a wedge resection, it shows it to be gist. What is your next investigation?
Sir, it shows, sir, in this case, sir.
Histopathology is gist.
Yes, sir.
What is the next step for this patient? The patient having a lump of 7 centimeter.
Sir,
You see, the lump size is important
yes,
here.
Sir. Sir, lump size, size is more than 2 centimeters. Sir, we'll go for, sir.
You have not done some more tests.
Sir, we'll see for the mitotic index.
So how do you categorize in histopathology the risks of gist?
Gist can be benign,
Sir,
borderline, or malignant.
Yes, sir. Sir, benign if it is less than 2 centimeter and less than 5 mitosis per 50 high power field. Sir, probably benign, sir, 2 to 5 centimeter, less than 5 mitosis per HPF. Sir, uncertain is, sir, less than 2 centimeter more in size and more than 5 mitosis per high field power, sir. Sir, low, moderate potential malignant, sir. Sir, 2 to 5 centimeter.
You need not tell us the whole thing. Everybody can read. Now, what you need to understand that the size criteria also varies from different anatomical locations of gist. Okay.
Yes.
Now, if it is the duodenum, even 3 centimeter will be considered as a high risk.
Yes, sir.
Okay. If it is in the esophagus, a 2 centimeter risk gist is a high risk. Okay. So the size changes depending on the anatomical location. By and large, if it is in the stomach, this holds true. Okay. So low risk, intermediate risk, and high risk gist. So you have categorized it. Then what is the next investigation?
Sir, immunohistochemistry.
Right.
What
Why
immunohistochemistry will you do?
Sir, immunohistochemistry, sir, will look for CD117 and CD34 platelet derived growth factor alpha. So these are usually respond to tyrosine kinase inhibitors, imatinib, and
What is the other group which does not respond?
sir, other group which wild type of GIST in which there is both CD117 and platelet derived growth factor alpha is absent. So,
Okay, so suppose you find that this is I mean it's negative. I mean c-KIT negative, PDGF negative. What other investigations you can do in this case? This is a tough question. Again, Toffee waits you.
Sir, if it is negative, sir, we'll look for other molecular like BRAF V600E and DOG1.
Yes.
Sir, Desmin.
Yes.
And sir, SDH genes.
Very good. You need there are two things to this. This is either a c-KIT negative GIST, where as you said, DOGS etc. is extremely important. The other one is it is an undifferentiated sarcoma.
Yes, sir.
So if you consider in the line of undifferentiated sarcoma, you have to delve into Desmin, S100, etc. to exclude the possibility of an undifferentiated sarcoma. And if you find the origin of the undifferentiated sarcoma, then the treatment goes in the another direction of systemic chemotherapy.
Yes.
Clear? So the entities can be a c-KIT positive GIST, a c-KIT negative GIST, or it can be an undifferentiated sarcoma. Clear?
Yes, sir.
Sir, I think
undifferentiated sarcoma advantage is what? Is the GIST chemosensitive?
No, sir.
No. But undifferentiated tumors, sarcomas may have some response to chemotherapy.
Sir, I think he has done quite nice.
Yeah. Because the point is, one should not get biased with the GIST. Somebody told you a GIST in the exam. Be free in mind that you approach the patient based on his presentation. Okay. If you start the patient on imatinib, and then how do you follow this patient up? Sir, because all patients may not be imatinib sensitive.
Yes, sir. Sir, we'll follow. We'll start the imatinib, sir, and we'll do follow up on 6 to 12 months with. Sir, we'll do other endoscopic ultrasound and CCT whole abdomen.
First is clinical. You see, clinical.
Sir, we'll look for whether the lump is progressive or sir, increasing signs further, or it is non-progressive.
So how will you do that? You tell clinico-radiologically. I will clinically and radiologically assess the response of the lesion to imatinib mesylate. Okay. Radiological, I think the best tool is ultrasound, because you are not actually looking at the operability. You are looking at the size, whether it is reducing. Finally, when you plan for surgery, yes, you can, for an inoperable GIST, you can redo a CT scan to see whether the fixed lesion has become operable or not. But in between, it's a clinical examination and an ultrasound to see the amount of reduction that is, or remission that is taking place because of the use of imatinib mesylate.
Yes.
Yeah. So you should, for GIST, you should be knowing the role of adjuvant therapy, and there are some situations where you consider neoadjuvant treatment. When some of these patient has got a 7 cm lump, when you do consider neoadjuvant treatment in this patient?
Sir, if the tumor size is larger,
in a large mobile tumor, you can always still resect. When
sir, partially resectable.
Or inoperable.
Inoperable. You see, the tumor has spread. Readily you can say that tumor has spread to the adjacent organs. Then there is a metastatic evidence. So in that case, upfront surgery may not be desirable unless the patient is bleeding or there is obstruction.
Yes.
In that case, you can wait, start the patient neoadjuvant, and then follow this patient up. Because that is the advantage of GIST with neoadjuvant, that most of the tumors will regress.
Yes.
And you can downstage the tumor also. Okay, Dr. Shortcut?
Okay, very good. I think he has done a very decent job. Again, I would put you definitely above pass marks. Only thing I would suggest is keep your reflexes intact and do not close your mind. Okay, at every level, your reflexes have to be kept intact, and you must be open to the suggestion of the examiner. Examiner is not contradicting you, but looking at your analytical power. That's what the exam is. Okay.
Yes.
But otherwise, well done, 7 out of 10. Thank you.
Good. Thank you. Thank you.
Thank you, sir.